All right, we're lucky to have our next speaker right here in the room, and that is Dr. Samar Rahal. She's a pediatric endocrinologist affiliated with the National Institutes of Health. In Bethesda, she received her medical degree from the American University of Beirut Faculty of Medicine and has been in practice for more than 20 years. She's currently working as a staff clinician physician at the Eunice Kennedy Shriver National Institute of Child Health and Human Development, and is the principal investigator for the natural history study for patients with Smith-Lemli-Opitz syndrome. Dr. Rahal.
Thank you. Thank you, Andy, for the introduction. Can everyone hear me? Perfect. Okay. So thank you for inviting me to speak today. As Andy mentioned, for the last 2 to 3 years, I have had the honor and the privilege of working with SLOS families. I have learned a lot from you. I appreciate your commitment and your advocacy for your children. It has been very inspiring. So today, what I'm going to chat with you about is a little bit about our natural history study, what it is we're doing, what are some of the questions we're trying to answer, and share with you some of our preliminary data. Do I have a clicker? Yeah, thank you. Okay. All right. Is that right? Okay. So this is the fancy title of our study. It's a natural history study, so it's not a treatment study. There's no intervention. We are collecting information about Smith-Lemli-Opitz syndrome in the natural baseline state. All individuals with SLOS are eligible to participate in the study. We do not have age restrictions. We do not currently have geographic restrictions. That was a little bit different when COVID was still very prevalent or more of an issue. But we do have, and again, thanks to COVID, we've learned that we could do a lot virtually. And for a lot of families, it is not easy to travel, especially long distances. And so we do have a virtual option for our study, which I will discuss as well. And then so for the in-person option, we invite you to come to the NIH in Bethesda, Maryland, and to spend about 4 to 5 days with us, during which we will do multiple evaluations. So those include history, and I mentioned that because a lot of my talk is going to refer back to this. A full neurodevelopmental evaluation. We have an amazing team of neurodevelopmental specialists, many of you are familiar with, who are very familiar with SLOS, have been seeing SLOS children and young adults for the last 20 years. Your child will spend a full morning or full afternoon getting assessed developmental progress, etc. As we just heard with our previous talk, GI issues, feeding issues are major concerns. And so again, we have a wonderful feeding therapist specialist who will assess speech and also swallow and feeding, and then try to give you some feedback and collect some information. As needed, physical occupational therapy, an eye exam, a hearing screen. And we just recently added a cardiac evaluation, which is an echocardiogram, picture of the heart, and EKG, which looks at the heart rhythm. For the virtual option, it looks limited, but I will explain to you that it actually isn't. We do a full history taking, which is invaluable, and we'll talk about why in a minute. And then we do a brief neurodevelopmental evaluation. So obviously, there's probably no match to actually observing a child in action right there, but our neurodevelopmental specialists can do a lot virtually, and so we did include that as part of our virtual option. And so we have many goals for this study. Like I showed you many different evaluations. We're trying to collect a lot of information about a lot of different things, but what I'm going to focus on with the rest of my talk today is answering this question. What issues and problems are occurring in young adults with Smith-Lemli-Opitz syndrome? And the reason we want to try to answer this question is because we get asked by families all the time, is this problem going to get better? Is it going to get worse? Is it going to stabilize? As my child gets older, what am I going to be looking out for? What are new problems that are going to arise? Are we going to be looking at new things we need to screen for, things that we need to prevent, things that we need to treat? And so we're trying to answer those questions. We don't have a lot of good data. We have what we call anecdotal evidence. We have stories, we hear from people. We're trying to do it in a research setting where we collect good data on long-term health problems in adults with SLOS, so we can try to answer those questions as objectively as possible. And then the more, the other question we do get asked as well is a little bit more difficult, but how do we plan for the long term? What is the lifespan of SLOS? What are we looking out for? What do we need to plan for? And, we do have these stories we hear, very rare, but we do hear about kids suddenly getting very sick for no reason we can ascertain. Can you help us explain those? And this is what the next few slides I'm going to present. These are the questions we're trying to answer through this natural history study. And that's why I said obtaining a clinical history is very important, because that's what's helping us answer these questions. So I'm lucky enough I came in 2 to 3 years ago, but SLOS studies have been ongoing at the NIH for the last 20 plus years. And so there we have about a database of 100 individuals who have already visited the NIH as part of previous natural history study. And so we contacted all of them if we had emails available, and we tried to invite everybody back, and you all are also invited. As I said, everybody with SLOS is eligible for the study. So we contacted everyone we had contact information for, and we, so far in the last couple of years, have managed to enroll 26 participants, and 8 of those, 30%, have had virtual visits only, and the rest have had a combination or have come in person. And so this slide shows you all of the 26 participants we've had so far. And I've broken down to show you the age. So mean age is the average age. And as you can see, that's about 18 years old. So we have been lucky enough to get adults with SLOS because a lot of the individuals who are in the study have actually gotten older, and now they still want to participate and give us information. But the range, like I said, everybody's eligible. We've had as young as 2 and as old as 38. The other side of the slide is the severity score, and this score is a score that is based on abnormalities present at birth. So when we try to come up with this, I'm asking you to think back to, very long time ago for some people, and asking you whether your child had cardiac malformations, the syndactyly, multiple digits, abnormal genitalia for the males, any lung problems, heart problems, etc. So there is a objective kind of scoring system for this, and it gives us an idea about the severity, at least at birth. It doesn't really account for what's happened since, but at least at birth. And so we had a good distribution of that. As you can see, the average was 17. We've had individuals as mild as 5. I don't think you can go much lower because syndactyly counts as 1, and most individuals will have that, and as high as 45, which is quite severe. So we've had a good distribution. Now I'm going to focus on the 16 who are above 16 years of age. So out of our 26, we had 60% who are above 16 years of age. I call them older adolescents and young adults. And I'm going to share with you what we were able to, the history that we were able to take from these individuals. And those who have participated, I see a few in the audience, hopefully some virtually, know that this is tedious. So unlike when you go to the doctor with a sore throat, they ask you 2 to 3 questions, do some tests, and you're done. This is not quite like that. This is asking you every system in the body and going through symptoms one by one. So for example, for something like heart, any heart murmurs, any chest pain, sometimes hard to tell with somebody who's nonverbal, any blood pressure problems, any blueness in the fingers and toes. So every system, and some of these questions can take a long time to answer. And this is where the virtual option is a good one, because with some families, they're like, I can only give you an hour at a time. And that's okay. We can split it and we can do it over 2 to 3 weeks and get all the information we need to make it as convenient as possible. But for us to get as much detail as possible so we can reflect it back to you and give you our findings. So this is busy, but I'll walk you through it. So what we're doing is, as you can imagine, if I'm asking all these questions, then I am gonna get a lot of different answers. So what I'm looking for is patterns. I'm looking for issues that come up over and over that I can say they're probably not just random. They're probably things that are occurring and that we need to look out for. Again, remember, these are all above 16 years of age. So what I highlighted there is everybody who's above 50%. So more than 50% of our participants answered yes to these questions. You can see difficulty sleeping up there, no surprise to anybody, and you can also see constipation, 50%. So I want to just say that for those two, and we just heard about constipation and how difficult it can be for infants and children. I will say that with the adults I'm talking to, it's becoming a lot more manageable in general as a rule, and that's good news. So most of these adults are either treating simply with diet, or they're treating with things as simple as Miralax done. So in a good, and with good results. Same for sleep. In infancy and childhood, it can be very disruptive for the family. In older adults, it's actually not as bad. So even though they report difficulty sleeping, it could be that it takes an hour to fall asleep, but then it's fine through the night. Or they're waking up a bit too early, like 3 or 4 a.m., but they're staying in bed. They're not disrupting necessarily for the family. So those two things, although they still occur, do not seem to be as significantly challenging. And then this is where I thought this is great news to share. So 75% were currently feeding orally. And we just heard, I'm coming right off the gastrointestinal talk. So as we all know, feeding is a huge issue with SLOS infants and children, a huge source of stress and difficulty and challenge. Well, we're finding with our adults that somehow with feeding therapy, good, proper GI care, 75% are actually able to sustain totally their nutritional needs orally. Now, I don't want you to think this is completely normal nutrition. So a lot of these individuals are needing pureed feeds, so not solid feeds, have issues with texture, might be gagging a little bit with certain foods, have food aversions, foods they won't go near, foods they want all the time, but they are not needing a G-tube to be fed. And if they do have it, they're usually just keeping it for medication or just, fluid intake when they're sick, etc. So this finding, the next finding I have highlighted is gait disturbance. Gait is a fancy word for walking. And about 50%, above 50% actually reported that walking isn't completely normal. So there's either challenges with balance, going up and down the stairs, needing to hold on to rails. Walking long distances can be tiring and need help and support with that. Transitioning surfaces from carpet to tile, as an example, is a little challenging. So we're trying, again, this is why this is good to do this research. We've highlighted this issue. We don't understand it well. We don't know why. Is it neurological? Is it musculoskeletal? Is it just simply anxiety? So we want to explore this further. Now that we know there's a good percentage, we are going to do a little bit more work on this. That's one of the advantages of doing a study like this. I put in endocrine. We didn't have the female to male was probably half, so that's not a lot of females. But I do put this up because it is a stress for families as girls grow older and go into puberty and are dealing with menstrual cycles. And I will say that puberty is occurring at a normal age, so are menstrual cycles. And a lot of our females were on Depo-Provera to help not eliminate, but control cycles or decrease the length or decrease the frequency that cycles are happening at, or other things like oral contraceptive pills, etc. So, but again, the numbers aren't big enough. We have added a consultation with our gynecologist, especially for the older girls, in order to address this a little bit in more detail and see if we can help families with this issue. Next, I highlighted the psychiatric/behavioral issues. Not a huge surprise, but I will point out that this is probably the major source of stress and a major challenge for families taking care of adults with SLOS. Anxiety is also a big one. And so we're working closely with Dr. Tierney to see if we can objectively assess anxiety. And some of it is from these kids are getting older. They're not going to school anymore. They're home with their parents and they have separation anxiety. So they want to be around their caregivers, all the time. And so there's some of that, but we're trying to look, further into this issue. For the infectious, I asked about COVID because I know that has been a concern. And luckily, you know, nobody has reported severe COVID, needing to go to the hospital or need oxygen. But most of our respondents, by the time I was talking to them, they've had COVID, were vaccinated. So that can also explain why. And finally, self-care is when we asked whether your child can take care of their personal hygiene, they can take care of their, dress themselves independently, make their own meals, that's a stretch, feed themselves. And about 71% needed some degree of help. Again, the numbers are a bit small to tease that out, but it did vary from needing, you know, 100% can't do much for themselves to, if I put the clothes out, they can dress themselves. If I give them the sandwich, they'll eat it. So there was a big variation there. So in conclusion, for this part of my talk, we didn't find any major new issues in adulthood, which is good news. Ambulation or walking may be the exception to this. We will be looking into this a little bit more in detail. I know Dr. Elias also mentioned this yesterday at the scientific conference. Many are now feeding orally and independent of G-tube. This is good news. And then behavioral and psychiatric issues remain the most challenging, which is why Dr. Tierney is so popular with us also. So the next part of my talk, the next few slides, I am going to discuss long-term survival in SLOS. So we did a little bit more with our database of, like I said, over 100 individuals with SLOS. I don't know if you guys are aware, I didn't know about this, but there is a database in the United States called the National Death Index, and it collects information on everybody who has passed away in the United States. And it collects things like their name, date of birth, state that they lived in, and social security numbers, etc., and also the date of death. So what we did is that we sent all the records of those individuals that we are not, you know, that we haven't heard from in many, many years. We sent them to this NDI, the National Data Index. And we asked them to let us know if any of these individuals have been confirmed deceased. So in total, then we had 107, again, you know, 27 that we have spoken to recently and who we didn't send to the NDI, but the rest, you know, we sent, and we got back that we had 17 individuals who were deceased. So that was about 16% of our cohort. We were given date of death, and we had asked for the cause of death. However, I will say here that it was disappointing. What we were looking for is whether it was cardiac causes or lung causes, you know, infection, etc. But what we were getting was multiple congenital malformations. So just a general term to say, you know, a lot of abnormalities, so not really specifically why. So that was disappointing, and we still need to figure out how to get this information so we can share with you. But what we have here is a couple of graphs. On this side, we try to look at the cohort who is deceased, you know, the 17 who were confirmed deceased, and compare that with those who we know are alive. And we saw that the severity score, this was no surprise, the average severity score of the deceased was higher than those who are still alive. But when we try to look at whether the severity score can predict the age of death, we actually were not able to tell that. What we were looking to see is whether, well, the higher the severity score is the age of death earlier. And there was absolutely no correlation, at least that we could find. Small numbers are always limiting with the quality of data that we get. And so given that data, we were able to get this, what we call survival curve. And so what that is it gives you the probability of survival at every age. And the ticks are when we know individuals at that age are alive, and the steps down is where we know somebody passed. So what this curve tells us is that there is a high probability of survival after the age of 20 years, which is good. We don't have enough numbers over 40 to make that same call. So we need, you know, our population is older now, but they're not that old yet. And so, you know, this is kind of how we chart that to be able to see it. What we next wanted to look at is whether those steroid levels, cholesterol, 7-DHC, were higher or were cholesterol being lower, 70HC higher in those deceased versus those alive. And we used our very initial sterol levels that we collected, and we found that for cholesterol, at least, there was definitely a lower cholesterol level in those who are deceased versus those who are alive. 100 is where you have that blue dotted line because that's normal. And so most of the deceased, their initial cholesterol levels were actually lower than that. So is the other cohort, obviously, but they were just a little bit better spread out above and below 100. So in conclusion for this part of the talk, we do have a 17% mortality rate, at least in our cohort. Age of death was not really related to severity score. The mean severity scores of the deceased were significantly higher than the cohort that is alive, and the cholesterol level, as I showed you, was lower. So what do we want to do next? We want to continue to collect data on or information on the medical history of young adults with SLOS so that we can have even better quality data and make sure our patterns are not a fluke and that they will hold. And then we would like to describe in more detail the medical history of the deceased population. So I'll take questions, but I did want to make sure I thank the Family Foundation for hosting this. This is incredible. I'm learning so much and enjoying meeting everybody. The families and children who have participated in our trial, I mean, I could have done nothing today. I could present nothing without their commitment. And I know it's not always easy. We try to make it as easy and smooth as possible, but we appreciate your advocacy. And then Dr. Porter, who's my mentor. Dr. Crowley, I put up there, he is head of the lab, the Porter lab. Part of our natural history study also is to collect blood work, urine, and when possible, cerebrospinal fluid from individuals with SLOS. And the lab does great things looking at biomarkers and trying to find, just correlations for individuals with SLOS and trying to find, why the brain neurologically, why we have these symptoms that we have. Dr. Audrey Thurm is the head of the neurodevelopmental team, and she is incredible. Many of you might know her. She is very enthusiastic about the SLOS research and SLOS population. And it's been just amazing working with her. I've learned so much from her team. Dr. Bianconi is who I've replaced. Many of you have met her and know her. She has big shoes to fill. Dr. Deng Do is still at the NIH, and she does another disease, but she helps a lot with our research as well and has been a great support for me. And then Rachel, Ash, and Tristan are IRTAs, so they're postdocs who actually spend a couple years at the NIH helping with these studies before they go on to medical school or nursing school. They are great support for us. They do a lot of the coordination. They are on site when you guys come in, just kind of being your escorts throughout the 4 or 5 days when you're here. And we hope to inspire them to do research on rare diseases because it's never enough. So thank you for your attention. And if we have time, I can do questions okay, Gretchen, yes. Do you have time? I don't want to, I don't know. Okay, go ahead. Yeah.
So we have plenty of time. We're going to go through noon because we're going to send out the video for the Sanford patient registry information. It's an 8-minute video. And then we're going to move the assisted where the protocol to go to a little bit later in the day. We're going to confirm the time on that. So you have until noon. But I was curious because some of us have been involved with the new study, the old study, we've been involved with this for many, many years since Marky was tiny. How many patients did you have in the old study and how many do you have in the new study, and what is your goal for that?
Yeah, that's a great question, Gretchen. And I do know that Marky's been there many times. The reason I know that is whenever we're trying to do research on blood samples or cerebrospinal fluid samples, I pull a lot of Marky's samples. So it goes a long way. It's, we store it as indefinitely and we do use it. And so we thank you for your commitment, not just to the foundation, but to our research. So I know it sounds weird, old study, new study, they're actually probably identical for all intents and purposes. It's more of a regulatory thing with our IRB. So the old study kind of fizzled out when Dr. Bianconi left, and then COVID happened. So we couldn't just restart it. We had to kind of submit a brand new study. But so in the process, we did maybe a few modifications you can maybe speak to, trying to make it a little easier for the families, a little less intense. So, we know your kids get exhausted, it's a long week, etc. So in the old study, we had about 123 participants, over 100, I know for sure, about 120. And so for this new study, like I said, we tried to contact all of them. Obviously, emails bounce back, people move, etc. But we are so far at 26. How much would we like to get? How many people are part of the Family Foundation? Did you say 1,000?
With all of our databases, now about 1,200.
We don't have a limit. We don't have a limit. We're not, it's indefinite. We're not stopping the study at any point, and everyone's welcome, and we just keep going. And that's the thing about research is, the bigger the number, the more reliable the data is, the better, the stronger the data is. So.
Well, just to give a little bit of testimony, because I'm sure there are a number of people that have been involved with the study, but since we were for so many years part of the older study, and Marky participated fully in all of the testing and had no problems with it, but the new study I found to be very family friendly. Not that the but it just kind of met us where we were. It was much more personalized. It was shorter in many respects. And with the virtual feature, I know that many of our folks, even a lot of the international folks, were very interested in that portion of it. So have you found that you've had a lot of international participants that maybe they can't travel over here, but they can participate in remotely?
Yeah, definitely. I mean, like I said, the virtual option doesn't sound like a very exciting option, but that's where all that data I showed you came from, so it's great. So international was an issue up until recently. And, with COVID, you never say never. But up till recently, there were a lot of quarantine rules. And so that basically made it almost impossible. You had to come to the US and quarantine for 7 days before you are allowed into the NIH. Well, it's not like you have a month, to do that. So we weren't getting international patients, but it's picked up. So I would say that that's been great. But obviously the virtual option is a good option for that. And like I said, Dr. Thurm's team is willing to do at least a brief neurodevelopmental assessment and share results of that with you. So that, that makes it the virtual option a little bit more, useful to the families. Yeah. Yes. Cool. Anybody? I guess we have time, which is great.
If we participated in the OHSU, I'm sorry, I'm back here. If we participated in the OHSU study, so Aiden's 20 and my other one is 16, and we participated at OHSU.
Okay.
Do you have that data, or is that something that?
Yeah.
I didn't
know.
Okay.
Yeah.
And
that's a good question, though. I mean, because it's a rare disease, we should do better with kind of sharing. But I don't know that we have a mechanism set up for that at this point.
Okay. And then this is sheer curiosity. So he was diagnosed in utero. So with my other one, somebody took my placenta.
Okay.
And so do you use tissues? I mean, over time, like, I don't know.
So so it still exists somewhere, or?
It's in a freezer in Texas is what they told me, is where they told me.
Really?
That's where they told me it was going, but she was outside with the
Interesting.
nitrous oxide. Ready
Yeah.
And I just didn't know how, when you talk about, cord blood, or when you talk about spinal fluid.
Spinal fluid, yeah. That hasn't come up yet.
Okay.
So that's
It's
a great
there
question,
somewhere,
though.
but,
It does come up
need it.
sometimes for cord blood. It comes up sometimes for cord blood. In any case, if we were to use any of that, you would have to be enrolled in the trial first, and then if it's a virtual option, then that might be something to consider, because we do like to get cells that we can grow over time and look at things that way. So yeah.
Okay, quick question. We were supposed to come out last August, but the guidelines were really strict at the NIH. And I wanted to know, what are they now? Have they loosened up some so we can go off campus, because we don't want to be stuck in there with a screaming child?
That's a great question. And it changes by the week. How old is your child?
She'll be 16 in November.
Okay. The Children's Inn is still hasn't complete. So there's a lot of restrictions that were present that have improved significantly. Things like you don't have to test before you come in, you actually don't have to test anymore on campus. It's more the children's end that has these restrictions, and it's kind of separate from us. We don't affect it very much. As of last week, as far as I know, they still were not allowing patients to go off campus. But why don't you check with me later and I will check, because they are changing on a weekly basis. Like I can't keep up. The reason I asked the age is because when that comes up, and it's a very valid concern, because what are you going to do with the rest of your time? There are other lodging, options.
It's just so much easier when you're right there at the campus. It's a short walk, and
Yeah,
like
you
you
just
said,
cross
we're
the
walking
street.
long distances. It's harder for her.
I know. Yeah. The official line at this point, as far as I know, is it's still not recommended or encouraged to go off campus. But we were hoping that's gonna, I mean, we keep waiting for that to change, because every single patient I've had come in is asking this question and is worried about this.
Hopefully when you get
we're
word, you
not
can send a
the only
mass
ones.
email out to everybody.
Yeah, I heard like freedom. Yes. Yeah. I understand them. I want to not, I want to say that the children's in-house is patients who are there for months getting bone marrow transplants. And so immune issues and infectious issues are huge. And that's why they have those rules. But for our population, it's not convenient. I completely agree. Yeah.
Hi.
Hi.
Kind of along the same line. So for the international requirements, so I'm from Canada.
Yeah.
Is there still a requirement to quarantine? No.
No.
Okay.
So we're good there. So
Okay.
like I said,
Okay.
a lot. You don't even have to test before you come in. Which
Perfect.
Is, yeah. So no quarantine. You can come right in, stay at the end, but then that rule is still active at this point.
I can deal with that rule.
Yeah,
Okay.
yeah.
It's
easier for smaller children. I think they do
Yeah.
have a playground, and Gretchen can talk a little bit about it from the so it's there's you could do a few things while you're there, but it can get boring. I understand. And DC is fun, so it's kind of nice to go out and explore if you're there anyway. So
Okay. My second question then, so in terms of the gait disturbance and the decrease in ambulation, so is that something that you're going to be adding to the study in terms of like an orthopedic exam during the NIH?
So Dr. Porter and I were just talking about this yesterday, because when Dr. Elias mentioned it, we're like, okay, there's definitely something there. We're seeing it, she's seeing it. We haven't talked about this, So what we are going to look into more like a physical therapy. I haven't been doing that consistently with all patients. I've only been doing it if somebody specifically asks, because a lot of you are already plugged in your communities, and we're not going to add much, to that. But we might just do that specifically for gait, for walking. So just kind of like an evaluation there. And so we haven't really teased out what we're going to do, but it was going to be like a specific evaluation.
Okay.
Yeah.
Okay. Thank you.
That's a good question.
Is this working? Yep. I just always like to hear what how old the oldest patient is.
Yeah.
I think I heard Dr. Elias say, she just left, I believe, but
Yeah.
she has one that's 60 something.
Yeah. I've heard that. I've heard 70s
60.
even. Yeah.
But
Yeah.
66, I think she said this morning. But
In our study, we had, as old as 38, but no, I've heard anecdotal reports of much older than that.
Yeah.
Yeah.
it grows,
heard
continues to grow,
70.
and that's very
I've heard 17.
inspiring.
What I found is honestly, health-wise, health is good. They're not in the hospital all the time. I mean, so that's very encouraging. In general, health is good. Yeah. Better than it was in early childhood. Gretchen, do you know? Do you have an answer? No. Oh, okay.
Hi,
I thought you were going to say.
one
sorry.
question. I have a 28-year-old
Okay.
that would fit with this study.
Definitely.
I've avoided the first one because I thought it was too invasive. We had a lot of behavior challenges to fly
yes.
from Seattle. to
Exactly.
DC.
Yeah.
But
I understand.
things have changed a little. It might be a little easier to get there. Is it still this new study? So what are the invasive procedures like?
Okay.
Do you need the spinal fluid?
Yeah. Everyone asked that question. So
Oh,
yeah.
sure.
So, you have to remember this is research. So everything on there is optional. We have had patients who opted against that, and that's okay. Having said that, I mean, Dr. Porter also left the room because he would stop me right here and say, but, so cerebrospinal fluid. So here's the thing. We all know that SLOS affects neurologically, right? And I want, no one's going to volunteer to have a brain biopsy, right? And we are not going to ask you that, and no regulatory agency is going to allow us to do that. This is kind of like the next best thing. We're trying to get a better look at the brain and what's going on around it. And this is the fluid that surrounds the brain. So that's why we do this. It's important for me, before I answer your question, to explain that that is the reason. And like I said, I wasn't kidding. I have pulled so many of your samples still, after years, because we find a new biomarker. And the scientific conference tomorrow, I'm actually going to talk about a biomarker discovery in cerebrospinal fluid. And we wouldn't have been able to do that if we didn't have those samples. So we appreciate those of you who, do volunteer for that and who do that. However, having said that, and let me talk to you a little bit about what it entails. We always do it under sedation. So we're not asking anybody who's wide awake to do it. No way. And then we always do it with trained anesthesiologists. We are trained. We do this over and over and over. And it's in sterile conditions. And so the risks are very low, but it's still quite invasive. So the reason we're sedating in the first place is our eye exams and our hearing screens. I didn't go into much detail, but they're very extensive. They might take a couple hours. We take a lot of pictures of the eye. It needs to be dilated. So that means eye drops. The hearing screen might take a long time to have those plugged in your ears and getting the ABR. So we're sedating anyway. So, well, while they're under sedation, could we stick a needle? I know it sounds awful, but get a little bit of spinal fluid, and we're only allowed to get 2 teaspoons. So it's not a lot. That's also, these are all to mitigate risk, to lower risk as much as possible. And most people tolerate it really well. Having said that, everything's optional. I've had people come in and say, I can give you 2 days, and these are the things I'm interested in. Data is data. What I showed today is not blood work, is not urine, and it's great. It's great data, and I want more of it. And that's just chatting. We could do that over Zoom, like I said. But then if you want to do like a neurodevelopmental evaluation, anything that you feel would be useful, we would do. So we can tailor it. And even though I put all those evaluations up, we do more of that. We have nutritionists who are willing to meet with you if that's what you're struggling with, GI specialists if that's what you're struggling with. For the younger kids, we're almost doing it every time. So I hope I answered that. We can talk, and you can let me know what you're comfortable with. At the end of the day, you're the advocate for your child, and you do what you are comfortable with, and we can make anything work. Did I go over? I don't have a watch.
No.
Oh,
I just have another question.
Yeah, go ahead.
No, knowing, there's the different issues that our children face with the eye and the vision issues that can happen over time. We really appreciate you being able to offer that to families in a safe way. I know Marky's always done it, and he has hearing loss, and then he's been able to, they've been able to collect that at the same time, and that has been, kind of, for us, it's been a very easy part. But I'm wondering, do you over time, do you publish then on the results of, what you see over time, because, the vision thing comes up quite often. And my second question is, have you ever considered, because this has come up as a question, any type of, I know that if somebody international can get themselves to the edge of the United States, you'll take it from there and help them travel, help them stay.
Yeah.
But have you ever considered an international natural history study joint effort with a physician overseas that could help your data? So kind of the use of the data, and do you publish with it? Do you, what do you do with it? And then have you ever considered expanding?
Great question. So first part of the question, yes, we absolutely want to publish, because that's the best way to get that information out to the community, other physicians who are taking care of SLOS children and adults. So recently, and I don't remember, I think it was 2019, a really good paper from our group. That was before I joined, so I can't take any credit, but Dr. Bianconi and others did publish on hearing. So that was using all that data that we had. And it did show that not a majority, but a good percentage had either mild or moderate hearing loss. If you had severe, but that's definitely a concern, and something that needs to be screened for, even if you're not in a research study. So what we don't know is whether that's stable over time or gets worse or gets better. which is a little unlikely, but whether it's stable or gets worse. And that's why when you join the study, you come in and then we ask you to come back in a year. Sometimes that's easy, sometimes that's not. But we want you to come back because we're trying to look over time as well. And that goes for the gait also. We're trying to see if those things are stable over time or if they get worse. And that's what that paper, it's a really, and I can share that with you guys maybe through Gretchen, but it's a really good paper on a lot of patients and their hearing screen. And we, like I said, what our next step is to see what's happening over time. For the eye findings, we have not published that yet. Dr. Porter's not in the room, but this is his pet peeve. There is a paper we are working on that has been written, but I think it was not accepted by one journal, and then COVID hit and we didn't do much with it. But those results are coming out, and I think we need to redo and put in the new data we have and see if we can find more. So that, maybe what we're doing this again in 2 years, I hope that paper will be out. It better be by then. So, okay, there was another part to your question. Oh, the international. Yeah, so yes, you're right. So we cover travel, but we don't cover international travel. So if you can get yourself to the US, we can take it from there. So we can't pay for the ticket from, I don't know, UK to DC, but if you come to New York, then we can, help with the travel, the internal domestic travel. Whether we have partnered with international, not that I know of, and we haven't gone there. So, but that's a great question. And I understand why. It's because there's, an entire population there that we could serve and help and learn from. But I don't know that I've heard discussions about that at this point.
I have just a comment in the context of what we've been talking about in terms of, well, I'll just say with regard to my son Juki, he's 22 now. He would not have willingly participated in extensive ear tests or vision tests, or not have been able to. So just the fact that he was put under sedation for the spinal tap, but for all of these tests provided by some of our national experts is an incredible opportunity, I think, for us and our kids. So I felt like I was really well taken care of, and that especially Juki was well taken care of every time we went to the NIH. So I say this, I know that many of you are nodding because you've already participated in this study, but especially for people who are maybe joining us remotely and are considering it, I would strongly encourage you to, not only because of your commitment to research, but because you'll get the sort of expertise focused on your child that you'll not likely find in your home communities. So keep that in mind.
Thank you,
Thanks.
Andy.
And there are a few more questions, quick questions online. Are there any indications that this gene is affecting males or females more than the other?
No, I mean, it's autosomal recessive, so there's no, that we know of, reason for preferential among the sex. So that's a good question.
Next question.
And our population usually goes 50-50. So, and I don't know if you guys keep those records, but probably that's what you find.
Next question is, my adult son with SLOS passed away at the age of 45. Would it be helpful for his mom to participate in the natural history study?
I'm sorry for your loss. And so interesting question, because yes, we do have, I didn't put that out there, but not only if you have SLOS are you eligible, but also if you are a parent of an SLOS child. And for that, we would only do like blood work, honestly. We don't really do, full evaluations because the parent is more likely to be a carrier. But we do have a database or a collection of blood from carriers that we, store in case we ever have a question that we need to answer. So.
Thank you. Next question is, how does someone apply to be part of the study?
Oh, that's an excellent question. You just contact me and we take it from there. Now, I would probably need Gretchen to kind of disseminate that information, or okay. Okay. I could share my email now, or yeah.
when folks sign up to be in the Smith-Lemli-Opitz Foundation, part of the questionnaire is actually, are you interested? And would you like the opportunity to connect with the NIH? And we make those connections. But they are certainly either welcome to come to our website, contact any of us board members that our information is there, and then we connect. But I'm sure you have information there. You're one of our board members. And so your information is listed on our website.
Yeah.
And so they
Perfect.
could really take us out
Yeah.
as the middleman once they're registered and just contact you directly. But if somebody is looking at this conference and they are not part of the foundation yet, it's a great way because it's within the form. So-
Yeah, yeah. So you're right. My information would be on the website and you could just email me and then we take it from there. Basically, we contact you and we do a screening call and start the schedule, figure out a time to join. So.
Okay, and the last question on here is very detailed and very scientific, so we'll hold that one till later so you guys can have a chance to look at it.
Okay.
Mine's not detailed or scientific. I have 2 kids.
Yeah.
Would you prefer, I don't know if you can even do 2 patients at a time. Do you have families bring them
If they're
together?
siblings, we can.
Okay.
Yeah, yeah.
And then second
We
thing
would
is,
just need heads up because then we would reserve that week just for you. So nobody else is there, but yes, absolutely. It's easier. I'm assuming.
well, it's not easier, but
Okay,
so
so
we'll
that's,
decide. I just want
you
to,
know,
I like to have all the, yeah, I like to have all the options.
yeah,
You would have a horde of
It's a little
adults coming
tricky
to help.
convenience wise. We've had it both ways and some families would just come in with one, say, oh, this is, this is super easy because it gives them a lot of time in between.
I only have one with me right now.
Yeah, I mean, there you go. So we can do either way.
Okay.
Yeah.
And then the second one is like with our ophthalmologist, he's had an eye surgery and is that passable information from research? I know there's different rules. Do we get
Yeah.
our own child's data? Like, so
Yeah,
that I could take.
from
yeah,
us?
Yeah.
Absolutely.
Okay.
100%.
Yeah,
We
that's
have
huge.
a
Thank you.
portal, yeah, but that's a good question. We have a portal that you can access and you can sign release of information. We send you everything. There's very little exceptions to that with the SLOS protocol. I have other protocols that I work on that because they're purely research, there's no clinical aspect to them. There's nothing to share since we're just answering questions, but this is not the case with SLOS. So your eye exam, your hearing screen, everything is available to you 100%. Yeah, probably the only thing I can't share would be, what happened to the CSF, that's stored for, or the blood and, the things that we store, but yeah. So good question.
Yeah, there are no further questions online.
Excellent. Well, thank you so much, Dr. Rahal, for all
Thank
of
you.
this information. I hope more of us will participate.
Me too. Thanks, Andy. Thank you.